today's episode on Myeloma Crowd Radio. I'm your host, Jenny Elstrom. We'd like to thank our episode sponsor, Takeda Oncology, for their support of Myeloma Crowd Radio. Now, it's Blood Cancer Awareness Month, and it's time to learn what you can do to help advance a cure. One of the easiest and most important things you can do is to share information to help other patients get their best outcomes. On the Myeloma Crowd website, we feature the latest news and information about myeloma. Another way to help is to help fund research. The Myeloma Crowd Research Initiative is funding 2 immunotherapy research projects that are cutting-edge projects to help all myeloma patients, but especially those with high risk. So take a look at this research initiative on the Myeloma Crowd site and share it with your friends and family during Blood Cancer Awareness Month. Now, we're thrilled today to have with us Dr. Robert Kyle. For over 60 years, Dr. Kyle has led the way in myeloma research, and he was a pioneer that defined and determined both the term MGUS and smoldering myeloma. So, Dr. Kyle, welcome to the program.
Thank you. Glad to be here.
Let me give a little introduction, a more full introduction for you before we get started. Dr. Kyle's groundbreaking work changed the way that myeloma was diagnosed and treated. He founded the Mayo Clinic's Myeloma, Amyloidosis, and Dysproteinemia Clinic. He founded a special protein laboratory and began collecting and recording data for patients with monoclonal plasma cell disorders. He's written over 890 peer-reviewed articles and over 1,200 abstracts. He received the David A. Karnofsky Memorial Award from the American Society of Clinical Oncology and the Wallace H. Coulter Award from the American Society of Hematology. These are the highest by these two groups, and he is the only person to receive both. Dr. Kyle is director and member of the Scientific Advisory Board for the International Myeloma Foundation. He's been chairman of the Myeloma Committee of the Eastern Cooperative Oncology Group, Secretary General of the International Society of Hematology, Inter-American Division, and member of the Editorial Board of Leukemia. The International Myeloma Foundation has established a Robert A. Kyle Lifetime Achievement Award to honor the physician who most exemplifies a singular dedication to and compassion for myeloma patients and treatment of their disease. And he continues his research at the Mayo Clinic today, even in recovery from knee surgery, which is just incredible. So, Dr. Kyle, we are so fortunate to have you with us, and thank you again for joining us.
Well, thank you for inviting me.
Well, maybe we want to start. Now, I interviewed you about 3 years ago, and you kind of gave a history of myeloma advances, but you have a specialty in these precursor disorders. So today I would love to focus on just MGUS and smoldering myeloma discoveries. So maybe you could start by giving us a little bit of history about how you discovered those in the 70s and early 80s.
Well, it actually begins a little before that. In 1964, I think it was, I saw a patient who was newly diagnosed with multiple myeloma, typical back pain, compression fractures, anemia, and also multiple lytic bone lesions, a bone marrow containing 30% or so myeloma cells, a large serum spike, and the patient had an obvious multiple myeloma. I advised therapy with her, actually with one of the 2 alkylating agents that was available at the time, cyclophosphamide, and the patient obtained some help, but died from the disease 9 months later. Now, I looked at her Mayo Clinic history, and here we have the histories of every patient's visit to the Mayo Clinic. And I noted that this particular woman had been to the Mayo Clinic in 1945, 20 years before. And at that time, she was complaining of fatigue, but her hemoglobin was normal. Other laboratory tests were normal, but the sedimentation rate was very high. It was in the range of 100. And the clinician seeing her at that time ordered an albumin globulin ratio, which turned out to be abnormal. Now, why in the world didn't the physician order a serum protein electrophoresis, a test that's available all over the world today? Well, the simple reason is that this test was available only in a research laboratory, and in fact, it took one technician 1 day to examine the serum from one patient, or the blood from one patient at that time. So it's pretty obvious that it was not a practical test to order. Today we do between 600 and 700 serum protein electrophoreses daily in our laboratory. In any event, the clinician also did x-rays of the bones and did a bone marrow examination and found only 3 or 4% plasma cells, which is normal, and very wisely did not recommend any specific treatment for the patient. She came back about 13 years later, and at this time she was asymptomatic and felt good. Her laboratory tests were still satisfactory, but now she had a serum protein electrophoresis, and this showed a typical M spike or monoclonal protein in the serum of about 3 grams per deciliter, which is pretty substantial. She was still asymptomatic and had no other changes. Her bone marrow was unchanged. She had no bone lesions, and so she was sent home without any specific therapy. And then a few months before I saw her in 1964 or 5, she developed bone pain and, as I mentioned a moment ago, had typical features of myeloma, which led to her demise. And so we actually published that case as a case report in probably 1966. And at that time, the M spikes had been recognized, particularly by Dr. Waldenstrom in Sweden, and he at first in the early 1950s called these patients as having essential hypergamma-globulinemia and advised no treatment for them. Then he developed, after a few years, the term benign monoclonal gammopathy, and that was the term used at the time that I saw this patient. And when we published the paper, we made the point that benign monoclonal gammopathy isn't always benign and that these patients should be followed. And then over the next decade, I collected, actually ended up finding 241 Mayo Clinic patients who had a monoclonal protein in the serum, a monoclonal gammopathy, but no features of multiple myeloma. And then over the years, when this paper was finally published, about 15 years later, with that duration of follow-up, we found that 1% of the patients with a protein abnormality in the blood progressed to myeloma or Waldenstrom's or to AL amyloidosis each year. And so at the end of 10 years, 10% of the patients would have progressed, and so on down the line. And at that time, we had data for up to 25 years. And when that first paper was published in 1978, I actually emphasized that 25% of patients who had, and then introduced the term monoclonal gammopathy of undetermined significance, MGUS, that some of these patients, 1% per year that is, would progress to a serious disease. And so I emphasized that, and in the paper, this alarmed many physicians and patients, and I began seeing patients who were just virtually scared to death that they had a 25% chance of developing a serious disease, myeloma, macroglobulinemia, or amyloid. Mm-hmm. However, I didn't emphasize that you had to live for 25 years before you had this degree of risk. And since the average age of a person with MGUS is about 70 years, if that individual is followed for 25 years, then during that period of time, there are many other things that will happen to us. That is, heart disease, strokes, other cancers that are totally related to myeloma and the plasma cells. So it becomes less of an onerous sort of diagnosis, and the patient is much better served by simply following that M protein. Mm-hmm. So that is a winded answer to your question, and if there are any other questions about any of the details, I'd be happy to try to answer them.
Well, one thing that really stands out to me is that you were able to make this conclusion because you had data, you had records that had been tracked and kept. So the value of having patient data that researchers can go look at over a long period of time is incredibly valuable.
Yes, we're very fortunate here in that we have records of patients going back to 1907.
Wow.
And just a few months ago, I had a email from a patient in Canada who asked me about his grandfather, and I was able to, with the date of birth of his grandfather and his address at that time, I was able to find his Mayo Clinic record, and sure enough, this patient had been here. He had a cancer of the stomach, was operated on, and then at that time, 1919 as I recall, patients were in the hospital for 10 days after abdominal surgery. And unfortunately, on the 8th or 9th day, the patient started running a fever, which turned out to be pneumonia, which turned out a fatal complication. And fortunately, an autopsy was done, and it confirmed the diagnosis of pneumonia. And it also showed that there was no evidence of any cancer left in the abdomen after this surgery for the cancer of the stomach. And of course, in 1919, if they had had antibiotics for the pneumonia, that patient could well have been cured, or at least would have had a significant duration of time until he had recurrence of his disease. So the record system is very important. The second thing is that I started collecting any serum, any blood that was left over after the tests had been done on that patient. Ordinarily, that blood sample is thrown out after a week's time because one cannot possibly store all of the serum samples from every patient. But any patient with myeloma or Waldenstrom's or amyloid or monoclonal gammopathy, I saved that serum, and it allowed us to go back with the record and the serum sample. And for example, my colleague, Dr. Vincent Rajkumar, back, a decade ago, looked at our patients, or a group of our patients with MGUS, and used a new test, that is, a test measuring the free light chains in the serum. We were able to find serum samples on the majority of these 1,384 MGUS patients, and this showed that the values for the free light chain measurements turned out to be an important prognostic feature for monoclonal gammopathy of undetermined significance. And I used to tease Dr. Rajkumar that we were able to do this study in about 6 weeks, and if we didn't have the serum bank, it would have taken 25 or 30 years.
Oh,
so
incredible.
Both and the serum bank are very important.
That is incredible. And before we talk about that, your look at this for over 40 years worth of data, I want to ask you about smoldering. So once you took a look at the MGUS and kind of identified that, how did you classify or define smoldering myeloma after you started making some of these discoveries?
Well, actually, the collection and I began abstracting the records of patients who had these particular diseases and started saving the serum in 1960, which would be 55 plus years that this has been going on. Well, we defined the patients with MGUS or MGUS as having a serum maximum level of 3 grams per deciliter and a bone marrow, if done, containing fewer than or 10% or fewer plasma cells, because at that point there was pretty much general agreement among people in the myeloma field to not treat patients or to not make a diagnosis of multiple myeloma unless the M spike was greater than 3 grams and the bone marrow containing more than 10% plasma cells, because it became obvious to me in seeing patients on a daily basis that some of these patients can have these high M spikes. In fact, I vividly remember the first patient that I saw with a large M spike. I was asked by one of my colleagues in gastroenterology to see this patient in consultation. He had an M spike that was about 3.5 grams per deciliter, and he had a bone marrow examination containing about 20% plasma cells. Both of those features fall into the diagnosis of multiple myeloma and merit treatment. However, this patient's protein abnormality had been recognized about a year before, and so when I walked into the room, I expected to see a patient who was pale, that is anemic, and who had back pain and so forth, but instead I saw this 65-year-old businessman who was completely healthy. and I asked him, of course, all the questions relating to myeloma. His answers were all negative. His laboratory tests, except for the M spike and the bone marrow, which contained 20% plasma cells, everything else was normal: hemoglobin, calcium, creatinine, bone x-rays, all of that. And I said, well, gee, a person like you, we ordinarily treat for multiple myeloma, but you look awfully good and your other laboratory tests are okay. If you promise to come back in 6 months, we'll delay the treatment. And lo and behold, he came back in 6 months and nothing was changed. This went on for 20 years.
Oh my goodness.
Then he then, at his return visit, he had large lytic lesions in his bones, but by this time he had developed congestive heart failure, which was attributed to coronary artery disease. There were no features of amyloidosis, and so this fellow actually, I decided not to treat him because he had no bone pain and no other symptoms other than his congestive heart failure, and any treatment that would contain steroids would cause retention of fluids and make his congestive heart failure worse. So we so I didn't treat him, and about a year later he died of congestive heart failure, but did not have any bone pain or any features of myeloma. So with this experience of seeing a patient for 20 years like this, I reviewed our cases and so forth and saw, I think it was 7 or 8 patients who had an M spike that was greater than 3 grams and had a bone marrow with more than 10% plasma cells, consequently fulfilling the criteria for myeloma, but who developed no symptoms over the succeeding 5 years, and labeled those patients as smoldering myeloma. And we have not treated them in the past, and some of those patients can go for 25 years without requiring any therapy.
Yes, that's an important, critical finding. And it's just, in hearing you tell these stories about these different patients and the conclusions you've made, it's not only scientific, but it's personal. You're looking at these people coming into your office, and I know you've seen probably thousands of patients.
Yeah, that's why it's important to see the patient, ask and take a good history on the patient, examine the patient, and take all of the laboratory features into consideration. And I always tell the fellows and the residents to do this when they see a patient with one of these conditions.
Mm-hmm. So I wonder, in your 55 plus years of research, now that you've seen the field evolve, what are your major conclusions about these precursor conditions? I know the International Myeloma Working Group has kind of changed some definitions over time, but maybe you could give us a high level, your just main key points about the changes that you've seen.
Well, first of all, you brought up the International Myeloma Working Group, and we have altered what we have done with patients with smoldering myeloma for a number of years. We have attempted to determine who is who, that is, who is going to progress within the next 2 years and who may remain asymptomatic for a decade or more. And that is not easy to do when you see the patient initially. So we're have been on the alert for features that would identify patients who would progress to symptomatic multiple myeloma within 2 years. And our goal is to identify 80% probability of progressing to myeloma. And then the next step, I could stop and give you some of those features. First of all, a patient who has smoldering myeloma, completely asymptomatic, has a bone marrow that contains 60% or more plasma cells. That patient is, in well over 80% of instances, will develop myeloma in less than 2 years. Another feature is patients who have a very high free light chain level, a ratio of greater than 100 to 1, and a abnormal free light chain level of at least 100. And also patients who have on an MRI have 2 or more abnormal bone lesions. Those patients are destined to develop myeloma. It's about 60 to 70% of patients within the next 2 years. That, coupled with therapy that is more easily given and is less risky as far as the patient is concerned than the conventional malphilan alkylating agents. What the alkylating agents consist of: malphilan, cyclophosphamide, BCNU, and so on down the line. Those alkylating agents put a patient at risk for myelodysplasia and actually acute leukemia, so we don't give alkylating agents, at least for longer periods of time, to patients. But now we have the novel agents, lenalidomide, bortezomib, and thalidomide, and those are much easier tolerated by the patient and much less risky than the old alkylating agents. So we are doing that, and then those patients who are designated as high-risk myeloma or high-risk smoldering myeloma need to enter prospective randomized studies to prove that those patients can actually be benefited as far as survival is concerned. Just lowering the M spike that is asymptomatic or lowering the plasma cells in the bone marrow may or may not stop the development of myeloma or macroglobulinemia or amyloidosis. So we need to proceed slowly and carefully and make that designation between so-called benign and malignant disease as accurately as we can.
Mm-hmm. Let me ask you a couple follow-up questions when you talk about high-risk smoldering myeloma, because I know some patients in typical or regular myeloma will say, well, excuse me, I might have high-risk genetic features.
Yeah.
But that's not necessarily what you're saying.
Well, high-risk genetic features are also are also a factor, but they are not associated with the 80% or more progression rate. It's lower. It's probably 50% or maybe 60, something like that. So it is a factor, but just because a patient has only quote, adverse cytogenetics or unfavorable cytogenetics does not mean that one jumps in and treats, because a patient can have these unfavorable cytogenetics and still not progress in a short period of time. One other point I will make is that that we're talking about 15 to 20% of patients will fall into the quote high-risk cytogenetic group.
Oh, okay. Yeah, and you have those genetic features even when you have smoldering, correct?
Yes, you can. Yes,
yeah.
yes.
Mm-hmm.
But it isn't a. But if you don't have any other features, that is the number of bone marrow plasma cells, the free light, the MRI, and that sort of thing, then you also kind of back off. Just because the cytogenetics are there and not other features, that's not an indication, in my opinion, to treat, and that is true for the International Myeloma Working Group as well.
Mm-hmm. And then what about circulating plasma cells or plasma circulating cells that you're finding in the blood for smoldering? Is that considered a high-risk smoldering feature?
Yes, but it depends upon the number of circulating plasma cells in the bone marrow. And when we first studied circulating plasma cells in the bone marrow, we looked at the peripheral blood smears, and that is a very limited way of recognizing circulating plasma cells. Now, with 8 featured flow cytometry, one is picking up a lot more plasma cells in the peripheral blood, and this is still, and the numbers are still being worked out, but that is and may well prove to be another important prognostic factor for patients with smoldering myeloma. Just more data is needed.
Mm-hmm. Now, before we get to kind of how people are treating smoldering myeloma now, or what you recommend, maybe we can talk about reasons for progression. So if somebody has this MGUS and smoldering myeloma, and there's a certain percentage who will progress and others who won't, are there factors that kind of trigger the progression that you found or that could potentially be prevented? Of course, anybody with these precursor conditions would love to shut it down early and get rid of it. But have you noticed in your research any specific factors?
Not really, not any reliable factors. And no one has been able to come up with a medication or a supplement or anything like that that is helpful in this regard. There was a study using curcumin for patients with MGUS, but that was unsuccessful and did not prevent MGUS from progressing. Now, looking at smoldering myeloma would be a better group to look at, because in contrast to MGUS, the risk of progression in smoldering myeloma is 10% per year for the first 5 years. And so that's the group of patients that should be looked at, I think, first for, quote, preventive measures in progression.
Mm-hmm. Yeah, that makes sense. And I think now that I know that many groups have now started to say, how can we shut this down? You mentioned lenalidomide and pomalidomide and thalidomide, agents that are not necessarily the harsh chemo-alkylating agents that you talked about. So let's talk about that. What are people using now for smoldering myeloma, especially for this high-risk smoldering group? And kind of where is the field going for that?
Well, first of all, there are protocols, and if a patient has smoldering myeloma, they should look into the possibility of getting into a smoldering myeloma trial. Just because the patient has high-risk features is not an indication to treat, because we don't know for sure whether reduction of the M spike and decreasing the number of plasma cells in the bone marrow will indeed significantly delay the development of symptomatic multiple myeloma. So these must be done, in my opinion, on a prospective randomized basis. There has been one study that has been reported from Spain in which the patients randomized to lenalidomide actually did considerably better than those patients who were not randomized to anything, but there are shortcomings in that particular study, and it needs to be confirmed, and that's why you, the patient, should get involved in a smoldering myeloma prospective randomized study if you possibly can.
Well, I want to echo your comment, because the reason that I started this Myeloma Crowd Radio series is to encourage patients to join clinical trials. Because 3 to 5% of myeloma patients will join clinical trials compared to some 80+% of childhood cancers. And you see what they've been able to do by people participating, and it's how we make these conclusions by getting this data and observing why people progress, why people don't. There are many smoldering myeloma clinical trials open now, and I know that Dr. Grobriel has one that's just an observational study, so they can collect some of this data like you have over the past almost 60 years. And I just want to echo that we completely encourage this, so much so that we partnered with a company called Spark Cures, because they've come up with a very easy to use clinical trial finder for myeloma trials. And so the language is simplified, finding a trial site is simplified. It's not as hard as it used to be, trying to go on clinicaltrials.gov and finding a study that you could join. So there is help if you are interested in joining a study. It's something that we can help with. So because we believe that this is going to help find a cure for myeloma faster.
I'm 100% behind that.
Yeah, we are too. It's just it's something that patients can do. Sometimes patients think, well, I'm just going to hope and pray somebody comes up with this cure. And I don't think we have the luxury of time for that approach. So I think anything that we can do to make this go faster or make your research come to conclusions faster is just in our self-interest. So a question about that. So Dr. Mateos, Maria Victoria Mateos of Spain, I know has done some studies with lenalidomide. She started that a few years ago. And like you mentioned, they were starting to use lenalidomide to treat. One of the questions that you kind of touched on a little bit that I have is some patients that I know say, I want to make sure that and lenalidomide has shown proof that it is effective to delay progression. But I think one of the concerns that patients have is, number one, am I going to have side effects that I need to deal with, even on a non-chemo type drug? Or will my myeloma, by what you said, killing it out of the plasma cells, will it make my myeloma evolve in a different way? So should I be concerned about getting early treatment if that happens?
Well, again, we just don't know, and one still has to keep in mind that there is no such thing as a safe drug, and that was taught to us 170 years ago. And if one looks at medical history, there are many, many drugs that have come and gone because they did not show efficacy when really tested. And secondly, some of these drugs have had unforeseen side effects. And that's particularly true with the alkylating agents melphalan. And we had used, the medical community had used melphalan for a decade, and then we noted in our practice that we had seen 4 patients who had developed myelodysplasia and acute leukemia, and raised the question as to whether the alkylating agent played a role. And then everybody started to notice this problem, and in fact the pendulum swung to the other side, making many physicians reluctant to use melphalan even for autologous stem cell transplant. And so it swings back and forth. Melphalan is a very good drug for myeloma, but there is a risk factor. But fortunately, the risk factor is very, very low if you get the melphalan in the high dose, 200 milligrams per meter squared. You're given that over 2 days, and the risk of myeloma, or the risk of myelodysplasia or acute leukemia is very low in those patients, in contrast to the individual who is given melphalan and prednisone orally for several years.
Right. Now, a question about lenalidomide. So doctors are using lenalidomide in early smoldering myeloma studies. One of the questions I have is it effective because it has anti-myeloma effects, or is it because it boosts the immune system? Because I've heard that it's an immune system booster.
It what?
Oh, it boosts the immune system.
Oh, boosts the immune system.
Yes.
Well, actually, the agents in this family, thalidomide, lenalidomide or Revlimid, and now pomalidomide or Pomalyst, are all members of the same family, each one a little better than the one before. And so these agents I think of them as having multiple effects. And certainly the immunomodulatory effect, the anti-tumor effect, they're all important. And it's virtually impossible to say which is the most significant for that individual patient.
Okay, that makes sense. Let's talk a little bit about immunotherapies in smoldering myeloma, because I think patients like the idea of using something that will boost their immune system to impact the myeloma without a lot of other side effects, because it just seems like that there are fewer side effects in some of the immunotherapy treatments than there are in some of the other drugs. So do you want to speak to that, about immunotherapy use for smoldering?
Well, it's a laudable approach and one that is still in its infancy. We used dendritic cells 15 or 20 years ago, and that provided a nickel's worth of benefit, but it was disappointing overall. Today, the CAR T-cell approach is a very interesting one, but it is it has very significant side effects, and there have been fatalities using that approach, and one is certainly limited in myeloma because half the patients with multiple myeloma are above the age of 70 years when they're diagnosed, and at present, one would not use the CAR T-cell approach in those patients at that age level. So it's something that is very exciting, very interesting, and but still the risk of side effects and the efficacy, I am sure, will be enhanced as time goes on.
Mm-hmm. Well, I think patients are excited about that and would like to see where this ends up going. So let me ask you, no, go ahead.
I was going to emphasize that patients do talk frequently about stimulating their immune system and so forth, but that is much easier said than done. And certainly we know that patients with multiple myeloma have a reduced immune system, and but to give a specific immune stimulator is just not feasible these days, and one should certainly be very cautious if they go to their health store and ask the proprietor for an agent that will stimulate their immune system. Oftentimes they are given and sold products that are purported to do that, but the scientific proof is pretty limited.
Oh, yes, and sometimes it can just kind of feed the fire, right, with cancerous cells. So you have to be really careful and make sure you're running everything by your doctor.
Well, and even the doctor doesn't know. None of us know, really.
Yeah, there was a story at my facility where they said one patient came in and was being treated for myeloma, and they were getting all the heavy-duty transplant chemo, and it just wasn't touching the myeloma. And I said, "What are you doing anything else?" And then he confessed he was taking this noni juice every day, or the Zango juice, or whatever one of these power juices are, and it was just making it spin out of control. So they said, "Please stop taking that because it's making your cancer cells grow even faster." I have a question for you. Now, I went back and looked at our first show. And in that show, you mentioned that heightened immunoglobulins in myeloma, one of those grows out of control, but that across the board, they were caused by allergies, or rheumatoid arthritis, or autoimmune disorders. So as we're talking about the immune system, do you think there's a link between myeloma and other inflammatory or autoimmune type of states outside of just the myeloma?
Well, are you asking, does a patient with rheumatoid arthritis or related connective tissue disorder, autoimmune disease, have a greater risk of multiple myeloma? Is that what you're asking?
That's my question.
In a nutshell, no. The evidence is extremely weak, and we've felt at one time that maybe rheumatoid arthritis is a risk factor for myeloma, but we've not been able to really prove it.
Okay. Well, let me ask another question. I know that some of these immunotherapies are going after certain targets, the proteins found on the surface of myeloma cells. And one of those targets is BCMA. So I interviewed one of the doctors who's working on a test to study BCMA levels because he found that it correlates with the M spike. So when the M spike goes up, the BCMA levels go up. When the M spike goes down, BCMA levels go down. So I just wonder if you've looked at the BCMA relationship in smoldering myeloma at all, or the MGUS state.
We have not looked at BMCA in patients with MGUS, so I just don't know. I am familiar with this person's interest, and certainly I would encourage him to continue to study it and to publish his findings as time goes on.
Yeah, I think that's kind of related to the CAR T cell stuff because I know a lot of targets are going after that particular protein.
Right.
Let's talk about minimal residual disease for a minute and some of the precursor conditions. In your opinion, what's the progress made, I guess, on minimal residual disease detection? And for example, I've heard that sometimes patients can go back to an MGUS kind of like state after they're treated. So, and then, we're doing more testing on patients now, I think, post-treatment to see if they've achieved this minimal residual disease status. And what would be your opinion on that?
Well, a patient who does achieve minimal residual disease has a stringent complete response, for example. And over the years, it's been difficult to measure the amount of remaining tumor, and we know that when you do the bone marrow and you find monoclonal cells in the bone marrow, that tumor still exists, even though the M spike in both the serum and the urine has disappeared. The hemoglobin is now normal, the calcium and creatinine is normal, there are no new bone lesions or anything like that. The PET CT doesn't show any activity and so forth. So the better results that a patient achieves, the better. But one has to keep in mind that every patient, at least every patient I have seen who has had a recurrence of his myeloma, is that the recurrence of the myeloma is of the same isotype. That is, if you have a G kappa myeloma, when that tumor recurs, it's a G kappa. It doesn't recur as an A lambda or anything like that. And that, to me, tells me that there are residual cells and original abnormal cells, tumor cells, and that if a patient has achieved the level of very minimal residual disease, that it will take a lot longer for that patient to relapse than it will the patient who has, say, a PR or even a very good CR, that sort of, or very good PR. So it's all a matter of degree, but one does have to keep in mind that when the myeloma recurs after any treatment, you always see the same type of protein as before. One time a number of years ago, I thought I saw a patient or had a patient. The patient presented with an IgG kappa, I guess, monoclonal gammopathy of undetermined significance. And this patient actually appeared 5 or 6 years later with multiple myeloma, but it was IgG lambda myeloma. And so I said, my gosh, has this patient developed another tumor, another plasma cell tumor, another myeloma? But I went back to the original sample that we had in our freezer, in one of our freezers, and looked more carefully at that patient's serum, and that patient actually had a very, very small second myeloma protein, and that second myeloma protein was the IgG lambda that subsequently grew, and it suppressed the IgG kappa. So when the patient had symptomatic multiple myeloma, we could find no evidence of the IgG kappa, and it was now IgG lambda. But that IgG lambda had been present in the original sample. So one has to be very careful in these situations. And one other thing that one needs to keep in mind is that we don't know the cause of multiple myeloma. We don't know. Is there something in the bone marrow that could possibly enhance or cause the myeloma, and that if all of the myeloma cells are killed, will new plasma cells be infected or damaged or made to become malignant? We don't really know that for sure because we don't know the cause of myeloma.
Yeah, I think there's a lot going on in that bone marrow environment that I know a lot of researchers are working to study. And it sounded like that patient was, so myeloma is usually monoclonal, or there's one protein that grows out of control. If that patient had the kappa and the lambda, would that be called polyclonal?
Yes, unless they're monoclonal. You see, probably 4% of patients with MGUS are biclonal. That is, they have an IgG kappa and an IgA lambda, or an IgM lambda and an IgA kappa, or something like that. And they have two proteins in their blood. And we have followed a number of those patients over the years, and they behave very much like the MGUS patient. That is, they progress or can progress to myeloma or a related disorder as you follow them over the years, just as an MGUS can.
Yeah, okay, interesting. Okay, my last question before I open it up for caller questions is what is the most important thing for either MGUS or smoldering myeloma patients to know and to do?
Well, I think the most important thing is for the patient not to ignore it completely, but to have the M protein measured on a regular basis, and the physician recommends to the patient how frequently that should be done. In general, I think if a patient walks into someone's office and the physician finds that he or she has an MGUS, or even a smoldering myeloma in particular, that serum protein electrophoresis should be repeated in 6 months, because there is no way to know whether this has just popped up in the previous few months or whether this has been around for 10 years. And so one needs to check it in 6 months, and if it's still stable, then one can recheck it at 6 months to a year, and the clinician makes that judgment depending upon the size of the protein and whether the uninvolved immunoglobulins are reduced or that sort of thing. But the critical thing is to be followed up on a regular basis, and not like some patients do. I don't have any symptoms. The doctor said this was an MGUS or even a benign monoclonal gammopathy. Emphasized to me that it wasn't causing any symptoms or findings, and that's true, but that can increase, and the patient can present with a broken bone or with kidney damage or a variety of things.
Mm-hmm. So I hear you saying regular checks, and I would add to that by a specialist, by a myeloma specialist, because I think they're testing. That's just my opinion, maybe not yours. But.
Well, I think that the patient's local physician can certainly recheck the serum protein electrophoresis. That's readily available, and if it's the same or stable and the patient doesn't have any symptoms, I think that it's okay to continue to follow that patient. But if the patient has a smoldering myeloma, or if that patient with MGUS increases some, then this should be seen by a hematologist, oncologist, who preferably has an interest in the plasma cell disorders.
Mm-hmm. And in my experience, going to a myeloma specialist versus a general hematologist or oncologist is just like a night and day difference, just in the testing that they require and or the watch that they do. So I highly recommend that patients see that. They can always get treated by their local facility, always, but I think it's always great to get an evaluation from someone that's a specialist in myeloma. And there's so many great ones that it just is a shame that if people don't. Well, Dr. Kyle, I would like to open it up to caller questions. So if you have a question for Dr. Kyle, and I have several write-in questions as well, you can call 347-637-2631 and then press 1 on your keypad. So we will start with our first caller question at 983-6757. Go ahead.
Good afternoon, Dr. Kyle. This is Dana Holmes. I'm a smoldering myeloma patient. Thank you so much for taking the time out and providing this platform for patients to speak to someone like yourself who's been at this and trying to find ways to cure this disease for so many years. Thank you from my own standpoint as well as our community, our smoldering and MGUS community standpoint. Appreciate it so very much. I do have a couple of questions, and I think I want to make a comment and support what Jenny just said about seeking out myeloma specialists. I am very active in these Facebook groups, and I always try to encourage patients, if they're able to and if their insurance supports it, to definitely seek out a consult at least once to make certain that everything is really being evaluated properly. And I recently had a member share with me that their local hematologist, oncologist, they don't even run, and this individual has smoldering myeloma, they don't even run an SPEP in that office because they explained to her that that's only a screening tool, that it's not needed to monitor further. And, you know, these are the things that patients unfortunately run into. So I definitely support seeking out a myeloma specialist that perhaps could set out the protocol for future monitoring if a patient wants to continue with the local oncology groups. Is that correct? Is SPEP only a screening tool, or should it be used to monitor going forward?
It should definitely be used to monitor the patient. If that patient has a small abnormality on the SPEP, initially the physician will do immunofixation to determine that it is monoclonal, number one, and number two, to determine the type. Is it GAM and the light chain type? So, and then if it is, then when the patient is rechecked, the SPEP is actually the first thing that the physician or the myeloma specialist, whoever, SPEP is the first thing that one would do.
Mm-hmm.
Now, I want to make one other comment, and that is that a general oncologist practice consists only 1% of a general oncologist practice would consist of multiple myeloma and the related disorders. So some oncologists are interested and knowledgeable about it, others are not. And so you can't really generalize about oncologists, but keep in mind that only 1% of the types of tumors that a general oncologist in practice in this country encounters is 1% of their practice. Every 100 patients that walks through their door would have myeloma or a related disorder.
Mm-hmm. So it would make sense to, at the very least, seek out a hematologist who may have more experience and or practice-related cases, yes?
It depends on the physician. And the old joke is that one practices hematology for fun and solid tumors, that is oncology, to put bread on the table.
Oh, goodness.
Well, stop and think.
Yep, I'm hearing it.
Yeah, one, quote, cannot make a living doing strictly hematology or especially myeloma unless one is at a large center. Mm-hmm. If you're practicing in your community and you don't have a particular interest in myeloma and patients aren't coming to you with a diagnosis of myeloma, only 1 in 100 will of the patients that you see will be myeloma.
Right. It's very unfortunate, though, because this is how patients fall through the cracks, unintentionally so, but nevertheless cracks. So we do try to encourage that in our Facebook groups and encourage folks, like I said, to even just, if you can, travel, do what you need to do, just even if it's one time, and then, be locally monitored going forward if you're not able to, do the travel, or if you have issues with your insurance company doing second opinions. Because it just makes so much sense to really have somebody at least with a really keen sense of the disease to review your case and make certain that you truly are on the right pathway. Dr. Kyle, I have another question because I was interested in what you described as the biclonal disease, and I know it's a very small proportion of myeloma. And I think I'm a little bit confused because personally I have a report. On my immunofixation, I always have something reported as an IgG kappa distinct band along with an IgG kappa faint band. So I never have two spikes. I only have one M spike. So I'm not quite sure if that IFE report designates me as a biclonal IgG kappa. Is that even possible?
Well, just a second. Let me go back and comment on the oncologist, the general oncologist in practice. Uh-huh. The patient can always encourage, if they're unable to come to a myeloma center, they can encourage their oncologist to contact someone at a center who is interested in myeloma, contact by email or whatever way that they can. And even if they don't have much experience with myeloma, they can delve into this a little bit more. And the other point I would make in this regard is that if a patient is able to get to a center, and the program for myeloma is outlined, or the patient on a protocol, then the local oncologist is very capable of taking care of giving chemotherapy to a patient with myeloma. They are very experienced in managing low white count, low platelets, and then altering the dose of chemotherapy and that sort of thing. They don't need to know a lot about myeloma per se.
Right. Okay, good point. Thank you. Yes.
Getting back to you with your IgG kappas, presumably, if you look at the electrophoretic pattern, do you see 2 spikes, do you know?
No, I've only had 1 spike reported all of this time. But the immunofixation will always state 1 distinct band and 1 faint band.
Okay. That faint band is very likely dimers of the monoclonal IgG kappa and of no consequence. This would be particularly true with IgM monoclonal proteins. With IgM and with IgA, one can get monomers and dimers of the monoclonal protein, and if the 2 bands are equal, then one can just add those 2 together and use that basic number. But just because you have reported on your immunofixation a second band, it is generally a small band, and if so, it's of no real consequence. And with you seeing IgG kappa in the or G kappa constituting that major spike, you're okay. Just follow that major spike.
Okay, excellent. Because I also have abnormal free light chains, but we've always and it's interesting because my spike has been so relatively stable over the course of since discovery, and my free light chains is the one that always kind of bounces around quite a bit, which I understand again is not uncommon to see either. So thank you for clarifying that for me. I always wondered what that meant.
Make 2 comments here. Number 1 is that about 1/3 of patients with MGUS have an abnormal free light chain ratio, and at least 50%, maybe 60% of patients with smoldering myeloma will also have an abnormal free light chain result, and those 2 are risk factors, modest risk factors for progression of the MGUS or the smoldering myeloma.
Yeah. All righty. Well, very good. And again, Dr. Kyle, thank you so very much for taking my questions, and so appreciate all that you continue to do for the myeloma community. Thanks, Jenny.
Okay. Thank you so much, Dana, for your question. We have another caller at 402-0809. Go ahead with your question.
Yes, hello. Thank you for taking my call. I'm a smoldering myeloma patient, and I wanted to know if any research has been done in correlation to thyroid disorders and myeloma.
What kind of disorders?
Thyroid disorders.
Thyroid. Thyroid.
Particular, yes.
Thyroid.
Thyroid, yes.
Yeah. No, there is no relationship, to my knowledge, of smoldering multiple myeloma to thyroid function, whether it's increased or decreased.
I see. In particular, I was treated for a parathyroid tumor, and it was successfully removed. And there is
benign or malignant thyroid tumor. Benign tumor, yeah. That would be very likely an adenoma, and that would have no effect one way or the other on your smoldering myeloma. Okay.
Some doctor sites had linked the parathyroid tumors to the formation of abnormal blood protein and the formation of MGUS. And I was just curious.
If that were the case, they're saying that the adenoma of the thyroid was producing the monoclonal protein?
That there was a link.
What?
That there was a link between patients with a parathyroid tumor that they would develop MGUS.
Thyroid or parathyroid?
Parathyroid.
Parathyroid, okay. No, there's no relationship. We did a paper many years ago and found no relationship between hyperparathyroidism and MGUS.
Okay, that's good to know. Well, thank you so much for all your work in this field and for taking my call.
Thanks so much for your question. Appreciate it. Okay, Dr. Kyle, we had just Paul who wrote in a question that he really wanted me to ask you, so I'm going to do that. He said, will you please explain the concept of secondary MGUS, and what are your thoughts on the impact of that secondary MGUS may have on both progression-free survival and overall survival, and or for PCL patients post-transplant?
Secondary MGUS? What does he? Any idea what he means by that?
I don't. I should have asked that question, but I didn't.
Yeah,
it could be. My guess is that that I hear some doctors, like we talked about earlier, say that you can go back to an MGUS kind of state, but I don't know if that's that question or what you're talking about biclonal. So I'm not sure. Maybe I'll have to clarify that and email you later.
Yeah, please do, because I don't know quite what he could also mean. After an autologous stem cell transplant, you get clones of plasma cells, and that can be called a secondary MGUS, and that generally signifies a active immune system in the patient, and then those M proteins after the stem cell transplant generally disappear within 6 to 12 months. And these are, if anything, a favorable finding.
Oh, that's good to know.
By secondary MGUS.
Okay, well, I will follow up. Yeah, that's probably what he was talking about. Well, great. Well, Dr. Kyle, we've kept you way over our time, but I just really appreciate you joining us today and talking about what you've learned with smoldering and MGUS myeloma. And I'm just thrilled at the research that you've done over so many years and the contributions that you've made. So thank you. We hope you keep going and continue to make more discoveries for myeloma patients.
Okay, well, thank you very much. It's a fascinating area, and I am glad to see and hear that patients and advocates like you are doing so much for the plasma cell community, the myeloma community.
Well, when we work together, I think we can support what you're doing, so we're thrilled to do that. So thank you again. And thank you. Thank you to all for listening to another episode of Myeloma Crowd Radio. Join us for future shows to learn more about the latest in myeloma research and what it means for you.
Okay, round two. Name something that's not boring.
A laundry? Ooh, a book club. Computer solitaire, huh?
Ah, oh, sorry, we were looking for Chumba Casino. That's right, ChumbaCasino.com has over 100 casino-style games. Join today and play for free for your chance to redeem some serious prizes. ChumbaCasino.com. No purchase necessary. Void where prohibited by law. 18+ terms and conditions apply. See website for details.